Assalamualaikum warahmatullahi wabarakatuh. My name is Nalendra Wicaksana, and today I'm going to present you about a Consort checklist of information to include when reporting a randomized trial. So there are 25 points in this journal, and the first one, the point 1A, is the identification as a randomized trial in the title. So the title is Effect of Aspirin versus Placebo on the Prevention of Depression in Older People. Then for the second point is 1B, unstructured summary of trial design, methods, results, and conclusion for specific guidance Consort for abstracts. So as you can see, there's importance, objective, design, setting, and participants, intervention, main outcomes and measures, and also results. Then for the next one, this point 2A is a scientific background and explanation of rationale. The preventive approach for many non-communicable disorders from cancer to cardiovascular disease have had major influence on incidence, morbidity, and mortality. Then for the specific objective or hypothesis, there are no evidence-based primary preventive pharmacotherapies for depressions. And the primary aim of aspirin was to determine if the use of low-dose aspirin reduced the risk of depression in healthy individuals 70 years or older or 65 years or older among racial or ethnic minorities in the US. As assessed using the Center for Epidemiologic Studies Depression Scale 10 item or CESD-10 scores. The secondary aims were to determine its effect on mental health quality of life, as indexed by the 12 item short form health survey or SF12, mental component summary scores, and assess the time to first CESD-10 score of 8 or more, as well as incidence of hospitalization for depressions. The primary hypothesis was that low-dose aspirin would reduce the risk of depression, defined as CESD-10 score of 8 or more at any post-randomization point. For the point 4B, settings and location where the data were collected. So it was in Australia and also in the US. Then for point 3A and also 11A, for the point 3A is the description of trial design such as parallel or factorial, including allocation ratio. And then for the point 11A, if done, whose blender after assignment to interventions. So the ESPRI trial was a multi-center, double-blinded, placebo-controlled, primary prevention, randomized clinical trial of daily usage of 100 milligram of enteric-coated aspirin among older adults who were relatively healthy and community dwelling in Australia and the US were 70 years or older. The trial was conducted according to the Australian National Statement of Ethical Conduct in Human Research. Australian Code for the Responsible Conduct of Research, the 2008 Declaration of Helsinki, and the International Conference on Harmonization of Good Clinical Practice E6, and was approved by institutional review boards at all sites. Eligibility criteria for participants was older adults who were relatively healthy and community dwelling in Australia and the US and were 70 years or older, or 65 years and older if African American or Hispanic and dwelling in the US. And then for the point 8B, type of randomizations, details of any restriction, such as blocking and block size. So randomization of the study drug followed a block randomization procedure and was stratified by site and age from 65 to 79 versus the above 80 years. 4.10, who generated the random allocation sequence, who enrolled participants, and who assigned participants to interventions. The trial was conducted according to the Australian National Statement on Ethnical Conduct in Human Research, the Australian Code for the Responsible Conduct of Research, the 2008 Declaration of Helsinki, and the International Conference on Harmonization of Good Clinical Practice (E6), and was approved by institutional review boards at all sites. The intervention for each group with sufficient details to allow replication, including how and when they were actually administered. And also 0.9, mechanism used to implement the random mass allocation sequence such as sequentially numbered containers describing any steps taken to conceal and sequence until intervention were assigned. A participant were randomized to receive either 100 mg of enteric-coated aspirin or an enteric-coated placebo, which were identical in appearance in ratio of 1:1. Study participants, investigators, and general practitioners, co-investigators were blended to treatment allocation. Then 4.6a, completely defined pre-specified primary and secondary outcomes measures, including how and when they were assessed. The principal outcome of variable of SPD was a proxy measure of major depressive disorder, defined as a CES-D10 score of 8 or more. Because some participants might have had a CES-D10 score of 8 or more at a baseline, or a history of depression, this primary outcome would both incident and recurrent depression. The CES-D10 is a validated self-rated questionnaire with a single factor structure that indexes depressive symptoms severity in community populations. When compared with a formal psychiatric diagnosis of late-life depressions, the scale has been shown to have a sensitivity of 97% and a specificity of 84%. Against a formal DSM-4 diagnosis, the sensitivity and specificity of the CES-D10 were 82% and 83% respectively. 11b, if relevant, description of the similarity of intervention. The scale has been shown to have sensitivity of 97 and a specificity of 84%. Against a formal DSM-4 diagnosis, the sensitivity and specificity of CES-D10 were 82 and 83% respectively. And for the point 12a, statistical methods used to compare groups for primary and secondary outcomes. The GEE models, assuming Gaussian distribution with identity link function, were used for analyzing the SF12 mental component. The GEE models accounted for within individual repeated measures using an unstructured working correlation matrix. The SF12 models use the same fixed effect parameter structure as the CES-D10 binary outcome models, and for SF12, the two-way interaction of intervention, allocation, and follow-up time estimated of the intervention effects as between group differential change from baseline score at each annual visit follow-up. The coefficient from the two-way interaction were reported as aspirant effect at each follow-up annual visit with 95% CIs. In addition, the effect for between group differential change was reported. Cox proportional hazard model were used in participants with CES-D10 scores less than 8 at baseline to compare incidence rate of CES-D10 score of 8 or more at annual follow-ups between the aspirin and placebo groups. Hazard ratios and 95% CIs were reported. Regression was used for comparing overall proportion of hospitalization at follow-up periods attributable to depression in the aspirin and placebo groups. And point 3b, important change to methods after trial commencement with reasons. The SES-D10 was initially administered at baseline at years 1, 3, 5, and 7. On receipt of further funding, National Health and Medical Research Council identifier GNT 1081-901 was added SES-D10 assessment to years 2, 4, and 6. Participants were thus assessed for depression annually until the end of their participation in the study. For the point 6a, completely defined pre-specified primary and secondary outcome measures, including how and when they were assessed. The mental competence summary score was a secondary outcome measure of SPRD. 7a, how sample size was determined. The target SPRD was sample size 19,000. To assess power for the SPRD primary hypothesis, we extrapolated from the extant literature that the risk of prevalent depression at any time in the placebo group would be 10%. We anticipated a 5% annual dropout rate and within participant correlation of 0.60 between baseline and follow-up measurements of depression using uncommon symmetry matrix. Based on this assumption, we have 90% power to detect the specified difference in depression risk, i.e. an odds ratio of 0.9 at annual follow-up between the aspirin and placebo group at a 5% significance level. For point 13a, for each group, the numbers of participants who were randomly assigned received intended treatment and were analyzed for the primary outcome. A total of 19,114 participants with 16,703 in Australia and also 2,411 in the US were recruited from March 2010 to December 2014 and randomized to receive aspirin or placebo. 9,524 participants to the aspirin group and 9,589 to the placebo group. The demographic and clinical characteristic of the participant at baseline according to the SES-D10 cutoff in both groups were similar. The mean age of the participants was 75.2 years in aspirin group and 75.1 years in the placebo group. And 95.31 of the participants were women. Regarding background, 16,007 participants were white and 16,463 spoke English at home. Details of the baseline characteristic of the cohort are published elsewhere. Point 48, dates defining the periods of recruitment and follow-up. The dates was from March 10 to December 2014. For point 18, results of any other analysis performed, including subgroup analysis and adjusted analysis, distinguished pre-specified from exploratory. Subgroup analysis of these participants showed no significant difference in the prevalence of depressive symptoms at annual follow-ups. Follow-up year by treatment group interaction. Further exploration showed no specific pattern in baseline adjusted depressive symptoms ratios at annual follow-ups, or range from 0.92 to 1.67. Antidepressant use was not statistically different between treatment groups at baseline or across annual follow-ups. Then point 15, a table showing baseline demographic and a clinical characteristic for each group So this is the table 1, which is a demographic characteristic of participants stratified by Center for Epidemiologic Studies. Depression 10 item scale or CSD-10, score of 8 or more at a baseline. And for point 22, interpretation consistent with results, balancing benefits and harms, and considering other relevant evidence. As pre-study in ascertaining endpoints and maintaining follow-up, this suggests that low-dose aspirin is unlikely to be effective in preventing depression in a healthy older cohort. And for point 16, for each group, number of participants or denominator included in each analysis and whether the analysis was by original assigned groups. Is on table 2, comparison of prevalent scores of 8 or more on the Center of Epidemiologic Studies. Depression 10 item scale or CSD-10 at follow-up in aspirin and placebo groups. Then for point 17a, for each primary and secondary outcome, results for each group and the estimated effect size and its precision, such as 95% confidence interval, was on the table 3, 12 items short from health survey mental component summary scores comparisons in aspirin and placebo groups. And for the point 20, trial limitation addressing sources of potential bias, imprecision, and if relevant, multiplicity of analysis. The fact that the S3 cohort had higher baseline quality of life than is not in other population-based studies of older adults probably suggests biased recruitment in favor of individuals who are healthy, a reflection of this primary prevention studies exclusive criteria. Point 19, all important harms and or unintended effects in each group. Goes on the conclusion. In summary, these studies failed to confirm any potential benefit of low-dose aspirin in reducing the risk of depression in this relatively healthy older population. This lack of efficacy is compounded by a clear increase in the risk of bleeding events documented in previous reports from this study. The findings do not support the hypothesis that low-dose aspirin can prevent late-life depression. 4.25, sources of funding and other support such as supply of drugs, role of funders. The funding or support is the SPD study is funded by a project grant from the National Health and Medical Research Council. The SPD parents study, which recruited participants and was responsible for all follow-up measurements, including clinical endpoints and other data capture, was funded primarily by a grant from the U.S. National Institute on Aging, with additional support from Australia's National Health and Medical Research Council, the Victorian Cancer Agency, and Monash University. Bayer Pharma AG provide matching aspirin and placebo tablets. Additional funding was received via a National Health and Medical Research Council Senior Principal Research Fellowship. Dr. Berg Doctorate and Program Grant, the National Institutes of Health, Dr. Murray, and the Heart Foundation Doctorate. The registration number and name of trial registry. The aspirin and reducing events in the elderly raspberry trial is registered on the international standard randomized control trial number registered ISRCTN A3772-183. The ESPRIT trial had multiple institutional review board approvals in the US and Australia. I think that's all from me. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.